Good morning, good afternoon, and good evening, everyone. And thank you for joining us for the webinar, Global Equity in Vaccination as a Sustainable Solution Towards a Healthier Global Population. My name is Anusha Khan. I'm a project officer with the International Federation on Aging. Today's webinar is the third in the three-part series, Driving Adult Vaccination Policy, which is a series of interactive policy dialogues built around issues for which immunization policy and action will improve and save the lives of potentially millions of older people. We are honored to be joined today by key experts, including Professor Denise Eldemeyer-Scherer, Dr. Ross Upshur, Dr. Asangeetham Akpan, and Dr. Chandrakant Laharia. We will begin today's session with opening remarks, followed by presentations from the speakers, and then a moderated discussion. Please use the chat function at the bottom of the screen to ask any questions, and during the discussion, the moderator will pose your questions to the speakers. This webinar will be moderated by Professor Denise Eldemeyer-Scherer. Professor Eldemeyer-Scherer is presently Director for Mona Aging and Wellness Center at the University of West Indies. Her academic interests cover both aging and public health lecturing and activity researching in both areas. She contributed to the development of the public health programs at Mona and also maintains her clinical practice. Throughout her academic career, Professor Eldemeyer-Scherer has remained a strong and passionate advocate for older persons, both locally and internationally. In recent times, she has focused on primary healthcare renewal from geriatric inclusion perspective. With the advent of COVID-19 and the targeting of older persons as a vulnerable group, she has advocated strongly for access to vaccines, including operating a vaccine center for older persons. Thank you, Professor Eldemeyer-Scherer, for joining us today, and it is now my pleasure to pass the floor to you.
Thank you very much. Good morning, good afternoon, and taking my cue, I'm also saying good evening since we are around the world. I want to thank the IFA on behalf of all of us, the speakers and those listening, for leading this effort in vaccines and stressing the need. The IFA has for over a decade been working to improve the global adult vaccination uptake rate by influencing policy and practice, and remains concerned in the midst of this pandemic that there is insufficient policy dialogue. I checked here and there is in fact no mention of older people in our vaccine policy. So I suspect that is a common feature for all of us. Immunizations are one of the most effective public health measures. We all know that, against infectious diseases, and COVID-19 has reminded us very harshly of this. Their effectiveness suggests the important role in global health security. Rates of mortality and morbidity around the world to the infectious diseases, not only the new ones that we have seen in Ebola and COVID, but the ones that we all have lived with, TB, measles. Not all of us have eradicated measles, polio, etc. And they suggest that vaccines, immunizations are not being used to their maximum efficiency. There is an uneven appreciation across the world as well. The low vaccine uptake in some countries, again, including my own, is evidence of this. For many of us, there is now a glut of vaccines, unlike the beginning of the vaccine campaign, and we are actually discarding vaccines. IFA, in its work on vaccines and their latest publication, which looks at the flu immunization, has highlighted the role played by inadequate attention to inequity, and that will be focused on today. Education programs are either universal or targeting mainly children. There are very few life course perspectives to vaccination that I could find in trying to prepare for this seminar. And we need targeted messages for all age groups. IFA is a leader in the campaign to increase adult vaccine through integrated country approaches. And again, today's webinar will highlight the obstacles as well as the challenges and the importance of successes. Most populations are aging. We are living in an aging world, whether we are in low, middle, or high income countries. And there are challenges to financing adequate health services for older people. Reducing the impact of the diseases that we can reduce the impact on is therefore key to equity for all in the healthcare approach, and especially in primary care. The current discussion needs to move from being a discussion and passion to effective policy and practice. IFA has convened this webinar to contribute to that conversation, that dialogue, and hopefully the start of action. We are very fortunate to be joined by three eminent speakers who have done a lot of work. Our first speaker, Dr. Upshaw, is currently the Dalai Lama Chair in Clinical Public Health and Head of the Division of Clinical Public Health at the Dalai Lama School of Public Health, Scientific Director for the Bridgepoint Collaboratory for Research and Innovation, and Associate Director of the Loonfield Tannenbaum, and I hope I'm not butchering the pronunciations. He can correct me when he comes on. At the University of Toronto, he is a professor in the Dalai Lama School of Public Health and the Department of Family and Community Medicine, affiliate member of the Institute for the History and Philosophy of Science and Technology, member of the Center for Environment and adjunct senior scientist at the Institute for Clinical Evaluative Sciences. He is a staff physician at Bridgepoint Active Healthcare Sinai Health. During COVID-19, he has served as the co-chair of the WHO Ethics and COVID-19 Working Group and is a member of WHACTA Ethics and Governance Working Group. He's an elected fellow of the Hastings Center and the Canadian Academy of Health Sciences. He is therefore more than able, more than competent, and we are very fortunate to have him presenting today on Driving Adult Immunization Policy, Global Equity in Vaccination as a Sustainable Solution towards a Healthier Global Population. You have the floor.
Thank you very much, Professor Elvmeyer-Scherer. It's a really great pleasure to be here today, and I'm grateful to the IFA for inviting me to speak on this important topic and to be joined by such distinguished colleagues. So I see my task this afternoon as more or less a scene-setting exercise, because I know in our pre-discussions, our colleagues are going to kind of put some meat on the bones. And what I want to focus on specifically is how we think about, how we reason about, how we understand this very important concept of equity, and then we can take it and apply it to issues with respect to vaccinating older adults. So everybody's probably seen these cartoon figures about the distinction between equality, equity, and justice, where you're looking at various different barriers or impediments to various people or humans or populations achieving desirable goals. So during COVID, and a lot of the work that our working group has been focused on, particularly with the ACT accelerator, of which COVAX is one of the principal components, this notion of equity and health equity has been very prominent. But outside of COVID and the pandemic response, health equity is really identified as a principal goal in public health and health system activity. But this really means that we need to get a grasp on what health inequity entails. And this, what I'm going to argue importantly, requires two components. One descriptive, that is what is the measured difference, and one is normative or ethical, and why does it matter? Why should we be concerned? Why should we be obligated to act in such a way as to reduce these measured distinct differences? So one of the most influential definitions of health equity and inequity has been advanced by a scholar, Whitehead. And the key issue here are health differences that are unnecessary, avoidable, unfair, and unjust. And this is probably the most cited and used definition in the literature. But as one of my colleagues, Max Smith, has noted, which health differences we consider to be unnecessary and avoidable will really be imbued with values about what we consider to be of greater or lesser necessity, beyond our control or not feasible to control, and what is fair and just will therefore require some form of normative assessment. And I've bolded here, and I think this is important because we're here to talk about how we engage with policymakers. If we leave the language of health equity, if it's left to be interpreted in an indiscriminate manner by policymakers, practitioners, and researchers, perhaps different and divergent interpretations will abound, and I can assure you that they do, because often when people are talking about a multivalent concept like equity, you find people often talking at cross purposes. So let's unpack this a little bit. So if the health inequity are differences in health between populations groups that are considered to be unjust. So as mentioned, that has two components, a descriptive and a normative. So the descriptive component means that you have data, and we're in a public health audience here, so usually some form of either a study, a public health assessment, in which you have contrast categories. That is, you have populations, and you're able to assess, vaccine coverage by age, gender, and neighborhood would be a great example of a descriptive approach, or the difference in life expectancy, say in Canada, between Indigenous and non-Indigenous Canadians. That's simply a description that there's a mathematical difference in a measure between two populations. But there's also this ethical component that we need to take very seriously, because we're making a judgment about why that difference should be viewed as ethically wrong or bad or unjust, such that it should count as a health inequity. And that means we need to understand what makes a difference in health unjust. What would a just state of population health look like? And I know one of my colleagues is going to talk a little bit about capability theory in his presentation. And what are the ethical standards or criteria we should use in judging whether a difference in health is unjust? So I want to introduce two dimensions of justice. One is this, what we'll call the currency of justice, the things that individuals are thought to be due, what they are thought to have a moral claim to as a matter of justice, because remember, health equity is concerned with, and health inequity is concerned with unjust and unfair distribution of these currencies. And so we might want to talk about outcomes that as a matter of justice, individuals or populations have a moral claim to the achievement of certain health states. That might be a typical life expectancy. It may be, a freedom from morbidity. Or we could talk about opportunities. As a matter of justice, individuals have a moral claim to the opportunity to be healthy, which may translate into educational opportunities, vocational opportunities, etc. Often, one of the most important things that gets discussed about in the relationship between justice and equity is resources. As a matter of justice, individuals have a moral claim to the resources that are conducive to bringing about health, income, healthcare resources, etc. Vaccines here would be the kind of resource that we're discussing. And finally, access. As a matter of justice, individuals have a moral claim to have access to the services that are conducive to bringing about health, that is, public health services, primary care services. So there's different currencies that we're trying to talk about. And then there's the principles of justice, which are the pattern or basis upon which the currency of justice can or ought to be distributed. And I'm only going to deal with 4 principles here. There are more, and I'll just say right at the start that we excluded libertarian considerations from this mix because it's largely a public health audience I'm accustomed to speaking with. So equality, as a matter of justice, we should aim to equalize that currency of justice, whichever of the ones that we're trying to work with. Sufficiency, that as a matter of justice, we should aim to have everyone secure a sufficient amount of that currency of justice, opportunity, access. priority to the worst off, or so-called prioritarianism, that as a matter of justice, we should prioritize the worst off when distributing the currency of justice. And prioritarianism is particularly influential in public health and accounts of social justice, which hold that the claim of public health in, say, vaccination programs is to ensure minimally that you're not making the worst off group more worse off, but you actually have an obligation to prioritize the worst off when distributing the currency of justice, whatever that is. And of course, one of the more common theories that most people are familiar with is maximization or utilitarianism, that as a matter of justice, we should aim to achieve the greatest net balance of the currency of justice. So you optimize the amount of utility. And so this then gives you a nice little matrix whereby you can think of how how the currency and the principles relate. And so when we talk about equity, it's obviously not a straightforward consideration. And what I recommend is that, you know, this table is very helpful when you're at when you're with a group of individuals who are trying to decide policy, and everybody is concerned with health equity. But are they clear on what the currency is? What is it that they're trying to distribute? And are they clear and in agreement upon what principles they're going to use to distribute those currencies? And it's not uncommon that you will have prioritarians at the table with equalitarians at the table with utilitarians. And there's a difference there, and those need to be negotiated. So what are some of the implications of this thinking for vaccination programs and aging populations? So I think, and I think this was made by our moderator, that there's a clear need to identify older adults as candidates for prioritization. So taking a prioritarian approach to the distribution of the currency of justice, where aging plays a role in increasing adverse outcomes for particular vaccine preventable diseases. And I think this claim is both empirically, descriptively, and normatively justified. However, as we're going to hear in subsequent talks, the bigger issues of global health equity relate to the global disparity in resources, wherein high-income country systems have abundant access and low and middle income systems have limited access. Now, there's multiple lines of normative argumentation to addressing this inequity, this global inequity as a priority in global health, and many of the documents that we've been working on during COVID through the pandemic with the World Health Organization have been making these cases about how to prioritize global equity on prioritarian and other grounds. But we must be mindful of issues around system capacity, and I think we're also going to have some discussions over issues around intergenerational justice. So how is it that a system is able to distribute usually finite vaccine resources to extend coverage to a broad population? So I'm going to stop there and hand over to the next speaker, and I hope this was of some benefit, and I thank you for your time and attention. Over.
Thank you so much, Dr. Upshur. A perfect start to our webinar. You certainly, and if I could just highlight some points for the discussion going forward, you certainly have set the stage with a practical definition of health equity and reminding all of us that we need to speak the same language by giving us the pointers. Also, as you did that, we were introduced to the concept that we will hear, as you said later, on the social determinants and some of the points. I think what was very important coming out was that it's not just about age and sex, but it's also about the conditions in which people live with vaccines. And of course, the issues around ethics and justice. And then you have given us the pointers for our discussion, some of the action points. And that, as you said, leads beautifully into our next speaker, Dr. Akpan, a clinical academic community physician with expertise in older people with frailty, interdisciplinary collaboration, and learning as core principles through which he advocates for and advances knowledge about the care of older people. He is also interested in the social epidemiology of older people, and his presentation today diversity in decision-making and global equity in vaccination will now take place. Over to you, Dr. Akpan. Welcome.
Thank you. It's a pleasure to be invited, and I'm really been looking forward to this. So thank you very much. And thank you to Professor Obsa for that great introduction. I'm based up in the northwest of England, and I'm a practicing community geriatrician, and I also collaborate with colleagues in local universities to do some research, mainly in older people. Sorry. Okay. Right. I have no conflicts of interest, and the views expressed here are solely mine. I'm going to go quickly over a brief background about myself so that it sort of will give an idea of why I'm passionate about this sort of topics. I'll briefly talk about capability and diversity and how that can influence decision making, and maybe some questions we have to ask ourselves when we're making any decisions. And then obviously, importantly, what can we do as policymakers, and some take-home messages. I've been very fortunate. I was brought up by a mother and father from two different cultures, raised in two different countries, and those experiences, I think, installed in me a sense of natural justice, where you could see people being treated differently. I myself being treated differently depending on where I was. And this extended into when I went for my postgraduate training in the United Kingdom, and I also spent a year in the United States. So I could compare and contrast those different experiences. And increasingly, in the last 7 years or so, I have become more interested in a public health approach and health equity topics increasingly. We usually are quite good at trying to be fair and providing resources to people in various parts of the world. But sometimes what we may not consider as much is whether people have the opportunities or the capabilities to actually make use of those resources. And Professor Amartya Sen has been advocating for this approach for many years, and in the United Nations Development Fund, they actually use his framework to try and implement and evaluate any programs that they do. So to be a bit more explicit, for example, if we're going to vaccinate people, say, anywhere in the world, we might deliver the vaccines and we might actually vaccinate people, but some people may not respond as well to that vaccine, and that might be because they are malnourished or they have other health problems, and therefore that limits their ability or capability to benefit from the vaccinations that we give. And what Professor Sen advocates is that in addition to providing things, we need to think about the barriers that might limit people from benefiting from what we're trying to do. More commonly, what we also need to think about, and I think we do increasingly think about this, is the infrastructure that can help us deliver the resources that we want to give. So for example, where are the vaccine centers located? Are they located in such a way that the vaccines can be distributed equitably? What is the transport infrastructure where we're going to be distributing the vaccines? Can people get to the vaccine centers, or can the vaccinators get to people to give the vaccines in time? We've had during the COVID very sad stories sometimes of batches of vaccines being destroyed because it could not be distributed and to get into people's arms in time. And also, are there cultural traditions? Are there some myths that prevent people from taking advantage of some of these things that we do deliver? And we may feel that we've done our job by distributing things equally, but the individuals who live in a particular area may have barriers that we're not aware of in accessing this. So these are some of the things that we need to think about. This is from a press interview this month, and the WHO Director General, made a very sad statement, which I think we're all aware of how things are. But he did say, "I don't know if the world really gives equal attention to Black and white lives. I need to be blunt and honest that the world is not treating the human race the same way. Some are more equal than others." And then we've had this report again issued in April, and it surveyed about 2,000 board members across 146 global health organizations, and only 25% of those seats were held by people from low and middle income countries. Only 1% of board members were women from low income countries, and almost half of the organizations evaluated had boards composed entirely of people from high income countries. As of the 14th of April this year, 65% of the world population had received at least one dose of the COVID vaccine, and this compared to about 15% of people in low income countries. Why am I sharing this? I'm sharing this because this is happening because we are different, and that is okay. There is no problem in being different. The problem is when we make judgments and decisions because people are different. And the difficulty is that these things happen insidiously and happen over time. So we make assumptions about a group, and this is usually learned when we're growing up from parents, from peers, and it's magnified by the media. And it's very difficult to change when we have stereotypes about people. And then prejudice sets in, which is a negative feeling about a group based on the stereotyping. And then we make decisions, and sometimes we're not aware of our unconscious bias when we're making this, especially if the group is very homogeneous and not diverse. And this can lead unintentionally to discrimination. So the questions that we have to ask ourselves, all of us, policymakers, whoever we are, is who are the people making these decisions? Where are they from? Are they representative of the global world that we live in? And if you remember that report, that board report showed that we are not. What are their affiliations? Which organizations are they affiliated to? Where are those organizations based? Who sits on those boards? Who funds them? Where is the vaccine research being done? And who makes the vaccines? Who benefits from it? And what about the distribution chain for the vaccines? How is that planned? Is there a global strategy, or is it only covering certain parts of the world? So what Dr. Ngozi Iweala says, she's the Director General of the World Trade Organization. I believe that when you find problems, you should also find solutions. So what can we do? Well, I just offer some thoughts for us to think about. So the first is research. Where is research being done? And when I talk about research, I speak in research in general, but also we can think about where is vaccine research being done. And there is no doubt that most of that is done in certain parts of the world, and in some, like in Africa, there is very little research being done. There might be, but it's not to the same extent. And as you know, research is funded, and out of that funds, institutions can develop, individuals can develop, the local economy can develop. So there is a lot of benefit from funding research equitably. And at the moment, that is not the case. Who are the stakeholders? And by stakeholders in research, I mean the people doing the research, the people who are the research participants. Where are they located? It's the same thing. They are located where most of the research is happening. If we were able to do this in a more equitable way, it means that the findings from our research will be generalizable globally. At the moment, we sometimes cannot translate research findings into some populations because we have not done the research in that group. And when we then try to translate those findings into that group, we find that things don't work because they were not involved in the research. We did not understand their issues and their context. I mentioned about the resources that comes with the research and the funding. So again, there will be some investment in those parts of the world where research is not normally funded. And also importantly, when people get used to research, especially those participating, they will bring increased trust in the process and in the outcomes. And that might help reduce things like vaccine hesitancy. What about vaccine production and distribution? There's been a lot of movement and work to try and get generic vaccines, to try and procure vaccines. But I think what we should be trying to think is more of a global strategy and build vaccine manufacturing plants in strategic locations around the world, aligned with a good distribution chain, and train the local workforce and the local universities there so that they would be doing the research and they will be running the vaccine manufacturing plants. Like India has shown very well the world what it can do. And I'm sure this can be replicated in other parts of the world, especially in Africa. And this would be an excellent way forward to be more equitable and to deliver vaccines quickly whenever we need them. Lastly, we need to involve stakeholders very early on. We need to leverage our existing partnerships wherever we want to do things. We should not just go in there with our own ideas and thoughts. We need to be respectful and understand that people on the ground have been advocating for years for older people and have been doing work. We may not know about them, but they are there and they are doing it. And we need to collaborate with them because they will guide us and they will make sure that the resources we bring will be used very well. And a good example of this is the National Senior Citizens Center that was opened in Nigeria about a year ago. And Dr. Omakaro is the first Director General. And prior to that, she'd been a great advocate for older people. She had a foundation, and the foundation is still there, where she campaigns for the health and well-being of older people. And I'm sure we have advocates like her all over the world. So my takeaway message for policymakers and for all of us is that we need to focus on making our decision-making as diverse as possible to reflect the global world we live in, so that the different challenges and barriers that I've discussed can be brought to the table and addressed. Thank you very much. I'll stop sharing now. Thank you.
Thank you very much, Dr. Akpan. And thank you for your very practical, you brought that passion and advocacy to the practical nature. At times when you started, I thought you were describing Jamaica, the throwing away of vaccines, the issues with transportation. So I suspect you speak for a lot of us on this platform today. You have set the stage for the discussions around diversity, capability, and you've also directed us to the key considerations when considering policy to add to what we had already on ethics and justice. And you have introduced for us that so important concept of research, that a lot of the research is done in the first world and does not translate to the cultures and diversity of other countries. So you have certainly added, and we are going to our third speaker, Dr. Laharia, also a medical doctor, but a columnist and an author who has been at the forefront of the COVID-19 pandemic response of India. Dr. Laharia is a leading medical epidemiologist, is among India's widely acknowledged public policy, vaccine, and health systems experts. His opinion pieces appear regularly in India's leading newspapers, and he has co-authored the book titled Till We Win, India's Fight Against the COVID-19 Pandemic. He is here today to share with us his opinions and his experiences, not only opinions, on driving adult vaccinations. Over to you, Dr. Laharia.
Thank you very much, Professor Edelmeier Scherer. Thank you very much, IFA, for inviting me to speak here. The previous two speakers with their excellent presentation had set the stage for what I'm going to share. So my task is almost half done. And so the topic or objective of this presentation, which I'm going to talk about, is a COVID-19 pandemic and vaccine inequity. We have heard from previous two speakers about inequities and various challenges in the world. But what we know, and especially COVID-19 pandemic, has highlighted various type of inequalities and inequity, and vaccines, which are one of the proven tools which require multiple interventions from the multiple level, have further flagged those challenges. So I'm going to focus about vaccines only, and then vaccine equity, which has become a key challenge and key issue in the COVID-19 pandemic response. What the theory is, what the principle is, that we know that whenever there had been a global discussion, every country, every public health expert, or every health expert, or everyone involved in pandemic response said that vaccines should be allocated for all the countries based upon needs, regardless of their economic status. But that's an intention statement that actually has not translated on the ground the way it should have. Allocating vaccines as per the needs of the country, regardless of economic status, but we also know today that there are countries which have administered nearly 85% up to 90% of population, entire population, with 2 shots, 3 shots, or maybe 4 shots to a large part of them. But there are parts in the world which have not received, even the 15% of the population has not received both shots. So those challenges are definitely there, and they have become more visible during this pandemic. Globally, the distribution of vaccines is shaped by challenging political, economic, social, diplomatic, or health-related matters. We know that vaccines require a particular process, the clinical trials and manufacturing and production, and these capacities are limited to a small number of countries across the world. And understandably, some of these countries are in high-income settings and also in Asia, but when around 15 countries have a capacity to produce vaccine and conduct vaccine research. And to ensure that vaccine equity is achieved, it requires a lot of global commitment. But what we have heard or seen in the COVID-19 pandemic, that while there has been a lot of talk, but that commitment has not translated into action. One of the key challenges that we have heard a lot about internationalism, that we should focus upon each of the country internationalism, but we have not seen what I would call globalism. And there is a difference in international and global. When we say that this is international cooperation and international collaboration is required, we still believe in the national boundaries and we still prioritize the needs of the nations. But when something is global, it essentially means all resources are pooled and distributed as per the needs. So what we need to achieve any type of equity is a global approach, not international or not bilateral approach. But this is a wishful thinking. In reality, what happens, we see the national boundaries or national interests always being far superior. I'm not saying that national interest would not proceed. This is the real world. National interest would proceed. But we also need to focus upon strengthening global institutions. So the resources are pooled and we are more willing to move from nationalism or internationalism to globalism. And that's my broader point. I'm just trying to make this full screen. So why vaccine equity is important? We know that vaccine equity is important, especially in COVID-19 context, that if we do not stop pandemic, and I have taken this slide from different sources, so it's not fully attributable to me. Many people have contributed in different sources. So 168,000 more children could die from malnutrition if vaccine equity is not achieved or pandemic is prolonged. 80,000 children would be risk of additional children would be risk of vaccine preventable diseases, because as we continue to live in the pandemic, there is a risk of routine immunization coverage going down or being halted, and not the routine immunization vaccines or traditional vaccine not reaching to the children. 1.6 billion learners could be affected due to persistent school closure or intermittent school closure. 2.5 million girls being at risk of child marriage over the next 5 years. The 20 years of poverty elimination efforts being at risk. And we know that vaccine nationalism will cost world $9.2 trillion in terms of economic growth or economic activity. I'm not talking about all of this in vacuum. The vaccine inequity is actually very real. As you can see here on the screen, that how different countries have fared on the vaccine coverage. And upper middle income countries, high income countries have administered far more number of doses per 100 people in their population, like nearly 200 doses per 100 people. So 2 shots per person has been received in nearly all upper middle income countries or high income countries. The lower middle income country, that number is like 1 shot per person. Essentially, it means different things, but we know that half of the number per person is administered in those settings. But what is more stark is the low income countries have a really, really low access. It shows that how inequitable the world is in the vaccine access. We also need to understand a few really stark figures that in high income countries, 3 in 4 people, or nearly 72%, have been vaccinated with at least 1 shot. But in low income countries, that proportion is only 15%. So 5-fold differences in a vaccine coverage, even with the 1 shot, and that is the kind of inequity we are seeing in the world. But then inequity is also linked to the economic aspect. Economic aspect that are those vaccines affordable for all countries. And one of the data sets say that vaccines are available for different countries at different rates. The cost or purchase cost for the vaccines is ranging from $2 $2 to $40. And in many of the cases, these are the lowest income countries or low and middle income countries which are paying the maximum or highest amount for 1 shot of vaccine. We know that Botswana purchased 1 vaccine which was being sold at $2 or $3 per dose to European settings, but Botswana in Africa paid $30 per shot. So that's the kind of cost. Of course, then in addition to the purchase cost, there are costs related to delivery, and these low-income countries, low and middle-income countries have a challenge in delivery also, because their health system is really weak. And for most of the countries, this COVID-19 vaccines are the first large-scale adult vaccination program. What does it mean in terms of the vaccine purchase cost, which indirectly, because if countries cannot afford, the vaccine would not be available. So what does COVID-19 vaccine cost to different countries mean in terms of economic cost or healthcare spending? While for high-income countries, the COVID-19 vaccine availability essentially means merely less than 1% of the increase in their health spending. But for low-income countries, the access to these same vaccines and ensuring availability of those vaccines to their population would mean more than 50% increase in their healthcare spending. So there are those kind of challenges, and I'm talking about not entire population being covered. 70% of population being covered in these countries would essentially means more than 50% increase in the cost. And of course, that is in the real world scenario, that is going to be challenging and not always possible. But the impact there would be impact of vaccine inequity also. And so it comes with a cost, like if countries want to try to achieve vaccine equity or vaccine availability, they have to spend a lot, but they fail to do, which essentially means economic recovery under vaccine equity, increase in GDP, like this is a simulation work, at the 54% of the vaccination coverage, essentially means that because of vaccine inequity and high income access, like most of the high income countries would have a good amount of increase in economic recovery, but the poor income countries, the impact of low coverage would mean that economic impact would be high on those countries. What is required? Like we know that majority of high income country or upper middle income countries have received 2 shots or additional booster shots, 1 or 2 shots. So total 10.9 billion doses of COVID-19 vaccine have been administered globally. But only 1% of those have been administered in low income countries. And low income countries continue to face multiple challenges of equitable distribution, identifying and locating the high-risk population, vulnerable group, securing vaccine storage, scaling human resources, planning delivery, and generating demand and uptake. So what required that the global community need to work together and work with those countries where vaccines need to reach, especially vulnerable population, ensuring and facilitating their supply. I would stop here and then I would reflect about India briefly without slides, that 2 actions are needed to key to addressing vaccine implementation challenges within the country. That one require understanding vulnerable group in society using multidimensional data, and then prioritization options would support national level vaccine rollout and vaccine micro-planning. Here I would like to reflect that in last 1 year in India, nearly 1.87 crore, which is 18.7 million vaccine shots have been administered. I'm sorry, the number is like 1.87 billion shots have been administered in India. And India has produced majority of these vaccines, or not majority, nearly all of these vaccines have been produced in India. But it could happen because India has invested for nearly 4 decades in vaccine services strengthening. Especially in last decade, there was a lot of focus and attention on strengthening vaccine service delivery, especially for new vaccines introduction. So India was doing a lot of work on vaccine introduction and new vaccine supply strengthening in the country. So the decade of work was behind. The second part is that India has some of the world's largest low-cost vaccine manufacturer, which supply vaccine to the rest of the world. Third part is that India was really a promise to the world, and in fact, before India faced a severe Delta wave, which really challenged India's healthcare system in April and May last year. Before that, India, as part of its vaccine Maitri or vaccine friendship program, till 31st March last year, India had exported more number of vaccines than the vaccine dosage used within the country. However, once the second wave started in the country, and then there was a serious sickness, like India prioritized its own population for vaccination, and then restarted the vaccine drive. But having said that, India today has covered, being a low and low middle income country, still India has covered 97% of adult population, which is around 940 million population, adult population is there, and of that 97% of adult population is covered with 1 shot and 80% with both shots. India is vaccinating also 12 to 17 years, but that's not a major priority. It is giving booster to a select subpopulation, not entire population. Vaccination for younger than 12 is not started. The learning from India had its own set of struggle where people were standing in the queue for vaccines, and there were some supply related issue. The situation only stabilized in last year, September, October. Coming to the last part, India did a prioritization exercise, and though in the first priority, the vaccination started for frontline worker and healthcare workers. That was the first group. But the second group, as per WHO prioritization, was the elderly. 60 plus population was the second group which India prioritized. And India has around 140 million elderly population. country started vaccinating this subgroup after healthcare workers, and there is a wide, around 90% of this population group elderly has received, or 60+ population has received one shot, around 80% has received both shots, and there was sufficient reasonable priority for this population group. When it comes to prioritizing this population group, this was again the same group which was prioritized when booster shots were opened, or third shot, which India called precaution shot, were opened for first opened, the 60+ population was given the third shot also. So this population group has been prioritized. Things have worked so well till now. Vaccines have a proven role. But having said that, the world is still facing the challenge that vaccines are not available to many of the people who should receive the vaccine. And that's where we need to work upon. Thank you very much.
Thank you so much, Dr. Lahari, and thank you for your very practical talk, especially at the end there, giving us the real life situation that you face in India and that extremely impressive number of 90% that had one vaccine. I think we all envy you at this point in time. Your presentation has certainly complemented the discussion as you have brought that focus down from the broader focus on ethics and equity into vaccine equity, and reminded us that the intergen approach, the life course approach, remains important. It is very important that as we stress vaccines for older people, that we don't go into competition and be seen as trying to take away vaccines for children. It's the life course perspective, and where do we integrate our competing, if I may say so, needs at times. As you highlighted the differences between the high and low income countries, I was reminded of the previous presentations. And when you think of that cost, and to think how much of that we are throwing away as we want to look at spending more money on health, and yet we are throwing away money, it's an important consideration, and thank you. Our speakers have been extremely disciplined in their presentation times. So we have a couple more minutes, and I am going to use moderator's privilege here. And I'm going to ask our two previous presenters if they have a comment or a addition based on what additional has been said to add. Not long, a minute, but if you would like to add to what's been said. Dr. Upshaw?
Thank you. Yes, excellent presentations by my colleagues. So picking up, I think, it's exceptionally important, as has been pointed out, that when we're thinking about sort of the just allocation of resources, that we actually take that EDI lens to those allocation mechanisms, because often the argument is that justice is blind, but actually justice may require that we're very clear-eyed in terms of acknowledging structural disadvantage and historical violence that's been perpetrated on certain populations. And that means that when it comes to the global distribution of scarce resources, such as vaccines, to pick up on the final ones, those curves don't require an ethicist to interpret that something is amiss in how we go about addressing collective global threats. And so we may want to actually have policymakers be strongly prioritarian, that is to sort of not hide behind sanitized epidemiological figures and say, where is the greatest injustice that is required, that we as a global community are required to redress? Now, I'll speak somewhat critically on some of the work that have been done. So for COVAX facility, for example, when the distribution mechanism was created, it was from a flat equalitarian calculus. All members of the COVAX facility would get vaccines to cover 20% of their population. And, it's just simply not the case that all countries are equally in need of 20%. Some probably, as we know, when you're in Canada, we had access enough vaccine to vaccinate us each 6 times over. So that might mean that, you know, those shares could go to systems that might need more than 20%. So this kind of, well, the fairest thing to do is allocate equal proportions. I think does injustice to the pre-existing injustice that these allocations were being made within. Thanks.
Thank you so much, Dr. Akpan.
Thank
Few
you.
words to add to the discussion?
Yes. I will echo what you said, that we're not competing or trying to take things away from other people or other groups. And let's think about this for a moment. Imagine that we could create the world that we want to live in, where we are all immunized across the life course, you know, for preventable diseases. That will allow us and allow the local populations to thrive, be healthy, be employed, the economy will improve, and things will generally get better. That is where we want to go. So this is not asking for charity. We're talking here what is sensible and where we want to go as a global community. Thank you.
Thank you so much. And as you reinforce the need for the intergen approach, I am reminded how many flu vaccines that we throw away each year. And we don't get across the message to the older persons, especially. Other vaccines, TED Talks, we are a very much agricultural community here. We have hurricanes, people get stuck with zinc and nails and they're not immunized. There is a post in the chat. Thank you, IFA, for your leadership. We're very fortunate because you may have seen her posting. She has posted in the chat directing us to 2 articles. And Dr. Jane Barrett is on this webinar with us, and I'm now going to ask her to comment. Dr. Barrett.
I don't think other than panelists, anyone can speak.
She's coming on.
Okay, all right. And thank you very much, Dr. Eldemir Shearer. And I might see if I can, right. Anusha, can you put my video on as well? If not, I'm very happy to talk with, okay. All right, that's all right. Look, thank you very much, Anusha. And also to Dr. Eldemir Shearer, Denise, thank you for the very careful moderation of this important panel. I think what I would really like to do is to actually just reflect on some of the trends that are happening now and ask the speakers to comment on, you know, vaccine confidence that is being reduced. Also, you know, how do we protect routine immunisation? Because lots of our discussion has really focused on COVID, and yet we know that there has been a dramatic reduction in routine immunisation around the world, and we do have measles outbreaks. I think the other thing that I wanted to just bring to our attention is that, you know, 2020, there was a dramatic increase in the percentage of GDP that was allocated to health systems. And that dropped in 2021 relative to pre-pandemic. And how is this going to impact, you know, the investment that's required in our healthcare systems? So I think because all of these issues really speak to the issue of equity and inequity. So how are we going to combat vaccine confidence? What about investment in infrastructure? And what do we do about protecting routine immunisation? So thank you very much, Denise, for the opportunity. And we are very proud to be associated with, you know, all of these colleagues on the line today. And as we know, this webinar is being supported by Pfizer. Thank you.
Thank you also, and thank you for your leadership over the past. Let's not say how many years we have been meeting around the world on this topic, Jane, but you have never given up on this, and we thank IFA, as has been posted as well, for their leadership.
Well, Denise, it's 2 decades come next year, so it's time for all of us to move to feeding the farm animals down the street. All right.
I agree with you. So we are now at the time for discussion. I'm noticing in the chat, another study has been published about demand. And I've already printed the one that was printed, the one by Anna Sangster. And I urge everybody to do this. I also urge you, I only see 2 questions in the chat, and I'm asking that we post some others. But while we do that, I'm going to direct this to Dr. Laharia. What are the measures that were taken by the Indian government to provide vaccination for elderly who had mobility issues or illnesses that affected their ability to access? And while he is getting ready to answer that, I'm going to ask our 2 clinicians to go all the way to the top of the chat. There is a question from England about an impact of the vaccine, and ask you to comment. So over to you, Dr. Laharia, first.
Thank you very much. So I think I'll field 2 questions, one on the vaccine confidence, and then what was done for elderly or people who were finding it difficult to get vaccination in health facility. So the vaccine confidence, I think one of the things which many of us in India think India did really well on vaccine coverage is that considering India's routine childhood immunization program, the full vaccination coverage range from 80% or 85%, which is really low in comparison of many other countries, and most countries achieve 95%. And then second factor that COVID-19 vaccines are the first vaccine being administered to adult population in India, such a large scale. Flu vaccine or other adult vaccination coverage is really low. So when COVID-19 vaccination started in India, or even the most optimistic individual were thinking that India might achieve a vaccine coverage of 60% or 65% of target population receiving vaccine shot. And after that, it will be really challenging for the country. And actually, India's COVID-19 vaccination drive started on slow note. There were not enough takers. And of course, the COVID-19 vaccination drive continued to remain voluntary. There was no mandate to get the vaccination. It has been voluntary from the very beginning. It is voluntary till now. In that backdrop, India achieved 97% of one-shot coverage for entire adult population of 940 million is what everyone in India is very pleased with. So it worked with multiple approaches, the science communication, but of course the severe second wave and then fear of third wave and actual Omicron surge contributed to tackle some of vaccine hesitancy or challenges. We faced the challenge, though overall adult vaccine coverage is 97% one shot, but that kind of coverage was not achieved for 60+ population. And which is again also very understandable that being voluntary, but 60+ population is the one, many of them in their lifetime would not have received any other vaccine. They might have undergone some treatment by preventive intervention they would not have received. So it was really challenging to convince those individuals, but at the same time, there had been lockdown restrictions, and going to vaccination center required some either adult family member taking the older person or the person 60+ person to the center. This was addressed through some of the innovations. What in the beginning, the vaccination sites were fixed site and some of those were further away. But what Indian government and Indian states did, that they started mobile vaccination centers. So the vaccine were taken each end of the village, Indian village, which is around 1,000 population, but even smaller hamlets of 200 people, 300 people, and every single habitation was covered through the mobile-based vaccination site. There were concept if there was some delay that closer to the home vaccination. And many of the Indian states also did a drive that vaccines were taken to the families or homes of the individual who were not able to come to the facility due to either some physical disability or long-term sickness. But there were concentrated effort to identify such population and ensure that they receive the vaccine. And that's how both increasing science communication or public communication to take vaccine, but also taking vaccine to the citizen. And both approach worked, and that's how India could deliver those vaccines to the population group, which, as I said in the beginning, even the most optimist would have thought that going beyond a certain level would be challenging. But
thank you very much. Just to add to that, when we were designated vaccine center, we were designated a senior citizen vaccine center at the beginning of the vaccine program. So we knew that our mission was senior, so we knew we were going to have the mobility issues. So we put a couple of things in place at the center: wheelchair access, or wheelchair taxis, we call them, to make them acceptable, ramps, etc. And we immediately started a car service where they could we would go out to the cars, which allowed them to put the stroke victims, etc., on the back of the seat. There was a very important and interesting consequence to this. We then became a center for children with special needs. Once people knew we would go to the car and they had their children with autism, etc., who they didn't want to obviously bring into a big space, they started coming and saying, will you do the children in the car, which we have done. Mark, we're 2.9 million people, so 2 million to be vaccinated, much smaller than India. We could afford to do that. But that was one way of doing it. The two other speakers, both clinicians, have answered Bridget. So it is suggested that it's not due to the vaccine and you need to consult. We have another post and another question which for us, and please feel free to post to the chat. What strategies do governments need to put in place to protect routine immunization and implement catch-up programs in times of austerity? I would also add to that, and to catch up, because for the last 2 years we have focused on COVID, and certainly for us here, our immunizations, our routine childhood immunizations have dropped from the high 90s down into the 80s. So it's catch up. Vaccine week is next week, I believe. Therefore, this question is very timely. So, Doctor, I invite persons who are on to post comments to this, but I will also ask our speakers, starting with Dr. Upshur.
No, thank you. It's a great question. I think we need to sort of situate the question in the pre-pandemic setting. Because I think what we need to have is governments committed to immunization strategies across the life course, and to sort of put pressure against the notion that we're always going to be in a situation of scarcity and have to make trade-offs within our populations. So, as a strong advocate for public health and primary care systems, we actually need to ensure that they are robust, well-resourced, and able to manage the volume that's going to be required for catch-up, and also knowing that many of those systems have been considerably stressed and strained. I know my clinical colleagues are exhausted from 2 years of COVID, and many have done and this means we need to get creative about who we recruit in to do the vaccination. So oftentimes we get caught up, at least in certain health systems, on who has the competency and capacity to deliver vaccinations. And one of my graduate students who's very interested in the concept of task shifting or task sharing has actually got a funded grant to get basically high school and university students to be able to deliver vaccines under the supervision of nurse practitioners and physicians. So that means you can expand the number of people who are able to deliver vaccines, which means that you might be able, if we're going to rely upon catch-up through either public health units or clinician offices, it's not going to happen anytime soon. The other thing I'd like to see is more discussion on how we can improve the global vaccine supply. Right now, there's a huge bottleneck, outside of India. There are very few countries in low and middle income settings that have the capacity to develop vaccines and have reliable stocks. And the issue here is that with investments, we could have sort of regional vaccine productions. And this will require, of course, pressure being put for patent waivers and IP sharing, and also continuing to strengthen primary care and public health systems globally. We conducted a Delphi study of experts in vaccine delivery systems, looking at what barriers they faced during the pandemic, and every one of the barriers and challenges and solutions were actually pre-existing barriers and challenges that vaccine programs were facing before the pandemic. So if vaccination is a global public health good, and we know it's truly one of the most effective ways of reducing morbidity and mortality in populations, the impact of vaccinations programs cannot be gainsaid. We'll maybe come back to the vaccine hesitancy issue a little later, but that's where we need leadership and political commitment and growth and investment in primary care and public health. It's nice to have acute care centers, but until every system in the world has a functioning and well-resourced primary care and public health system, we're not going to get ahead of this. Over. Thank you.
Dr. Akpan?
I will advocate that just like we've done for HIV and TB, we can leverage existing community health workers and train more people to be community health workers. Just like Professor Upshaw has said, we don't need to have doctors and nurses doing this because that would not be feasible. What we can do is train others to administer the vaccines, and I think we can do this through that existing network. We can see how complicated HIV treatment used to be, that we had people who had no secondary school education and they were able to monitor and administer this medication, and same for TB in different parts of Africa. Closer to where I work at the moment, we're using pharmacists and we're training interested health workers who may not routinely be involved in vaccination, but who are interested, and they are being trained up to administer this to relieve the pressure on doctors and nurses.
Thank you very much. And Dr. Laharia, any thoughts on that? Especially since you've got to 97%, how did you get the policy makers to do that?
So, well, in India has a vast network of vaccination centers through our primary healthcare network, and there is a special group of vaccinators who are involved in this process. 200,000 vaccinators, they are called auxiliary nurse midwife. They are especially trained for vaccination, but also for maternal and child health services. So those were used, but of course nurses and other, rarely doctors, nurses or those vaccinators deliver these vaccine services. What I would say, but interestingly though, India has achieved 97% coverage here for vaccination. But for routine vaccines, India's coverage has always hovered around 70% or 80%, 85% full vaccination coverage. In my opinion, considering COVID-19 vaccines have been delivered at a particular pace, this is also an opportunity for India, and I believe for many other countries which are doing this, to strengthen routine immunization program. Though temporarily there have been some challenges, but India has used learning in the past to improve vaccination coverage from polio elimination program. So India reported last case of polio in 2011, and since then, the microplan and other details which are used to reach every possible habitat, every possible last child, those approaches had been used in the polio elimination program, and some of those learnings have been used in COVID-19 vaccination. But I believe it's time that COVID-19 vaccination learning and system is strengthening in terms of newly trained vaccinators, to strengthen cold chain capacity, strengthen attention on micro planning and identification of vulnerable population. All of those could be utilized for strengthening the routine immunization program, other service delivery. If we do not do that, I think it will be a missed opportunity. So the temporary shock to the routine immunization program can be compensated by, if learning from COVID-19 vaccination can be utilized and system strengthened can be utilized for, again, reviving the routine immunization vaccination.
Thank you very much. And Christina has posted that we need to integrate our systems in the integrated approach and now integrate routine immunizations with the COVID-19. So persons coming for their COVID-19 can be offered a slew of others that are available, whether it's seniors or anybody. And Jane has posted something that we've all been talking about, but I'm not sure what we've done given the GDP and the impact of COVID on the economies of small island states, that the pandemic has exposed the inadequacy of the primary healthcare system and the tertiary. Many of us had to put up field hospitals. I know in Jamaica, for example, there was a point that we ran out of oxygen. And I've heard of other countries the same. So the inadequacies of all of our systems has been exposed by COVID, and we need greater investment in infrastructure and coordination. I'm going to add something to that. We have been talking about what governments can do, what policymakers can do. We also need a vehicle to convince them. And as public health advocates, I think that role falls to us. We have to find ways. Dr. Laharia has found a way in terms of being a columnist and writing. Are those of us that are convinced of this, that have been in the trenches, that have been out there during the pandemic, whether we are from the public health side or whether we are from the tertiary side, seeing the people with difficulties to breathe? Are we making enough noise? And are we making it to the policymakers? In other words, not only publicly and highlighting the one or two cases, but are we finding the means and the ways to get to our policymakers and to point out to them some of the issues? And some of the suggestions that have been made are very basic. They just haven't thought of them. So I think it's also about us finding our way to get into these policymakers and finding one policymaker who is an advocate and asking them to take it all the way to the top and to the cabinet and to the decision makers. But it's not enough to simply say we need to get the policymakers on board. As Jane reminded us, this is 20 years of work for some. We will be leaving the scene. And as my first boss told me, you won't have made your mark if the work stops when you leave. So we need to find that policymaker to start nagging. We still have 10 more minutes, so.
I just want to jump in there. I think we need to create spaces where we can engage with policymakers. Some of the other studies I've been looking at, so, having worked on normative guidance documents for the World Health Organization for member states, we're wondering whether there's any policy receptor and uptake. And I thought it was kind of a unique thing because most people don't like to talk about ethics very much. But then I started to do, with colleagues, a couple of studies on the experience of science advisors during the pandemic. And they had the same frustration with policymakers. So policymakers during COVID seem to have developed, I won't say a bunker mentality, but they were dealing with a rapidly evolving, highly complex, uncertain landscape. And we're looking for, we didn't actually know what they were looking for early enough on. So I think if we're coming out of this, we need to find ways to bring policymakers into discussions earlier rather than later, and to find a common language where, we can, because there's not a policymaker who's going to say they're against equity in any shape or form, but what is it they understand it? What are the mechanisms that we need to ensure are in place to be confident that we're going to achieve those goals? So I would like to see a much more robust interaction between, they tend to sort of button down in the ministries and not come out and look around very much, but they need to be permitted to by their political leaders to engage with community groups, with academics, with researchers, so that we can come up with a form of language that's going to work for us. Over.
Thank you very much for that important contribution. And Dr. Akpan, anything to add? Any of our participants wish to add something in the chat?
Yes, so I wanted to add that usually in most countries you have charities or societies that advocate for older people, and politicians and policymakers tend to engage with them or go to them when they want to do things, but nothing stops those charities or organizations from also approaching, making that first step. So in the UK, we've got the British Geriatric Society, we've got Age UK, and we've got quite a few charities that do make a lot of noise and are influential. And in Nigeria, as I said, in the last 1 year, we've got the National Senior Citizens Center, which is already making a lot of inroads and meeting ministers and trying to influence things.
Dr. Laharia?
I think I don't have any additional point to add on this aspect.
One thing that I would like to add, we've been talking today about vaccinations, and we have focused on senior citizens. This is an opportunity for the advocacy groups for seniors. Never before have seniors been the focal point of attention. We did one study here, and seniors, the world was accused initially of being ageist in protecting the rights of seniors until the public health people pointed out that we had the right to, or they had the right to consider the population. When we did a survey here of our seniors, they actually were grateful for the attention. From the senior citizen point of view, from the policy and advocacy point of view for healthcare in general, this is an opportunity we cannot miss. For example, many of my people know the voting population of seniors. They're higher on the voters list than many others. Let us also use this opportunity to get the seniors, the healthcare needs, the social needs of seniors on the front burner. So it's an opportunity. As we say, for every disaster, there is a silver lining and there is an opportunity. People are taking note of seniors at the moment, policymakers are. Let us piggyback on that to ensure that we get some of the things that, as Jane pointed out, we've been trying to get for 20 years. So Dr. Akpan has posted on the senior citizens groups, and Jane is saying, could the panelists comment on the degree to which health literacy contributes to the immunization inequity in the older population? And we have 5 minutes and I need 2 minutes at the end. So Dr. Upshur?
I think, health literacy is one thing, but the real novel feature of these last 2 years has been misinformation and the use of social media. So, and that's something that I don't think anybody was prepared for. It's really, I've worked on epidemics going back to SARS-1 in Toronto, so over 20 years of work on outbreaks. I think we can never underestimate the importance of health literacy, and it's yet another thing that in an integrated system that supports primary care and public health, health promotion and health literacy are considered core to the mission of those organizations. So that way you can actually start to immunize populations against misinformation about the value of older adults, et cetera, et cetera. Over.
Dr. Akpan?
I think what I've noticed here in the UK is that we've used trusted people that people trust and to trust. So their GPs or community leaders that they trust to counter those misinformation. And the same in Nigeria. Trusted community leaders are approached and they usually have good influence.
Dr. Laharia?
I think one of the approaches that in health programs, we rarely use the politicians. So sometimes we use celebrities to convey the health messages, but in this COVID-19 pandemic, especially to the different vulnerable groups, all possible medium of communication, especially in vernacular, and also engaging the locally elected representatives were used. And that's how even the people who were either disinclined to get vaccination or other health services, or even those who otherwise would have used the traditional system of medicines or now never exposed to the vaccines, but with the use of political influential voices, celebrities, locally elected representatives, and the communication in the vernacular actually did a lot of made a lot of difference in improving immunization coverage.
We have 2 minutes left, and I need to give Anusha the last minute. Any final words, any final takeaway message, Dr. Upshaw? And we do need to be brief on this one before they cut us off.
Thanks for the opportunity, and a pleasure serving with my panelists, and thank you for your expert moderation. Fantastic.
Thank you. Dr. Akpan?
I think it's just been great. Thank you very much.
Dr. Laharia?
Thank you very much for this opportunity. And I think we have definitely many lessons how to tackle any type of health inequity from the COVID-19 pandemic, and we should use those lessons.
And let me also say thank you for the opportunity to moderate. And I do believe this has been a wonderful webinar. Anusha, I'm over to you now.
Thank you so much, Professor Eldermeyer-Scherer, as well as Dr. Upshaw, Dr. Akpan, and Dr. Laharia for your valuable contributions to this very important discussion. With this, our Driving Adult Vaccination Policy series comes to an end. We thank Pfizer for supporting this series through an unrestricted grant. As a recap, our first webinar focused on immunosenescence as a proxy for high-risk populations and immunization policy. The second webinar discussed combating ageism as a policy lever in the delivery of vaccines in long-term care facilities. And today's webinar highlighted the importance of global equity in vaccination as a sustainable solution towards a healthier global population. These are indeed very important conversations to have, and they require urgent attention. The resources for this series will be made available on the IFA website and the YouTube channel. I also want to thank Ms. Berenice Anaya and Dr. Jane Barrett from the IFA for their support and their work on this series. Thank you to everyone for joining us today, and have a great day. Bye. Thank you.